Welcome to our ninth topic, which is the final and last session for this program. I hope you have enjoyed um, learning with us, and I hope that you managed to complete the course and get your certificates. We are now going to focus on monitoring and evaluation. Um, so the goals of monitoring and evaluation is to determine the extent to which a program like 3HP or TPT, as we call it, is reaching its target. So if we have targets, how far are we? The data we collect is helping us to make informed decisions regarding the operation, service delivery, and how best to implement TB preventative therapy across the districts and facilities in our country to ensure the most effective and efficient use of resources. So we are able to tell which facilities have more cases than others, and how then do we support those facilities to be able to care for the volumes of clients. But where we have a very low uptake of TB preventative therapy, what challenges are there and how do we go about supporting those facilities? And then also to establish the overall impact of the program. So if we have 60% coverage TPT for people living with HIV and AIDS, what is the expected impact on new cases of TB? If we get to 100%, what is expected? So every work that we do, we need to be able to collect data so that we can see whether we are doing the things that we need to do. And as we do those specific actions, are we having the expected impact? But also in terms of monitoring the negative impacts, whether it's adverse event, side effects, patients not completing treatment, or defaulting and interrupting treatment. Information is key to inform the kinds of decisions and protocols we might need to put in place. So the whole process starts with data collection. There's a patient record folder. So remember, in terms of people living with HIV and AIDS and TB patients, there is the standard clinical stationery where clinical and patient level information is documented, right? So we want to encourage that we continue to use the standard clinical stationery. We ensure that we complete it fully, because when we document our work, we are able to account for what we have done. But then it means the information that would then later be captured on the electronic register called tire.net would be a true reflection of the work that has been done, right? At primary healthcare level, we still have TIC registers, which are, I would say, they are manual registers, where on a daily basis, all the data, all the work that has been done is then collated and compiled on a daily TIC register, and summaries of this information are then submitted on a monthly basis for reporting through the district health information system. So information, for example, on number of people who were screened, how many were eligible, and how many were finally initiated on TPT would then be reported as such. We know that the HIV information system and TB information system are now integrated into one platform, tire.net. And we believe that the information about TB screening, eligibility, and initiation should be captured on that system so that we are able to track cohorts of patients until they complete, when they are transferred in, transferred out, and so on. So this is going to be very valuable, right? So the way the district health information system works is that data is collected from the patient clinical stationery or folder. It's then captured into an electronic register where data is dispatched on a monthly basis for reporting on a quarterly and monthly basis to the sub-district. Sub-district data will then be exported to the province, and then the province to the National Department of Health. You can see the specific timelines, like facilities must have submitted by the 5th of every month, sub-districts by the 10th, and then districts by the 15th, and so on. And some facilities use web DHIS or DHIS2, where there is live capturing. That means when data is captured at this level, it is immediately available at different levels for us to look at. So we do not want to create a parallel reporting system for TB preventative therapy. We want to enhance and strengthen existing data management systems. So TB preventative therapy data will then follow and flow upwards using the standard already approved processes. And then we will create a feedback system where data as submitted is then reviewed, analyzed, and then given as feedback so that this data can then be used for improvement of this program. We want to encourage facilities to conduct cascade analysis in terms of TB preventative therapy, so that you are able to assess in a specific period as determined by yourselves, whether it's a week, a month, or a quarter, the number of HIV positive patients who were eligible for TB screening, how many were actually screened, and then how many were screened as not having symptoms, and how many were assessed as eligible after you exclude contraindications, then how many were started, and what proportion of those who started actually completed TPT. You might even have to look at TPT by types, whether INH monotherapy or rifampicin plus INH, and so on. So we encourage facilities to have their cascade so that you are able to identify gaps and leakages where some patients who are eligible are not started, or those who are started, go on and on without being assessed whether they've completed or not. And this feedback would then be used at different levels. There'll be a provincial cascade, national cascade, district cascade, and hopefully we all get some time to sit down and analyze this data and do some root cause analysis processes and ensure that systems and process gaps that might be impacting on our performance are addressed. Where there's a need for ongoing training and education, we can refer people to this e-learning platform so that they can complete the training, and hopefully we get it right. We have a huge coverage in terms of TB preventative therapies, and we start to have a significant dent on the new TB cases. And by God's grace, in the next 5 to 10 years, we end TB and we have a celebration. So now that you have been trained, don't wait for anything. There's not going to be a bell. That's it. Bling, bling, let's start. No, we have to start. You have to start, and then you learn. As you start, have a culture of learning and then improving. We don't have to wait for a perfect situation for you to start. There can never be a perfect situation, but we will get to a perfect situation after a series of iterations where we try, we learn, we do, we act. So Peter says, what gets measured gets managed. So if we cannot collect data, we can never know whether we are doing the work. We can never see that there are gaps. So help us to get a true reflection of the work that is done by completing your clinical stationery, ensuring that those records end up with the data people and are captured, and then do your cascades so that you can see the gaps. Adopt a continuous quality improvement process where within your facility, within your unit, within your ward, you have a plan around how you are going to go about implementing TB preventative therapy. You monitor on a weekly basis whether the plan is being implemented, as planned. If it's not being done, you review, why are we not implementing? If you are implementing, now you need to check, is it working? You know, is your cascade looking nice? Is your coverage going up? Are all HIV positive patients screened for TB? You know, and those who are eligible, are they started or not? You know, and then based on your results, when you check, you need to act by either reviewing your processes, implementing new procedures, doing your in-service trainings for your clinical teams, and then planning your next cycle, doing it, checking and acting. And the idea is that as you do this cycle, you know, by the time you get to your fifth, sixth cycle, you start to get to a perfect state, you know, where your performance, your team performance is very optimal, because the whole team on a weekly basis, you are sitting down, you know, to review your doings against your plans and whether what you are doing is getting you closer to 100% of eligible patients being put on TPT. If there are critical gaps, you then analyze and act, you know, as needed. And it's not a one cycle, it's probably a series of multiple cycles helping you to get closer to your goal. So Mark says continuous improvement is better than delayed perfection. So let's not wait for a perfect time. Let's start, learn, and improve. Thank you very much. I hope this was a great experience for you. It surely has been a great experience for me. And I look forward to engaging with you further on other training programs and ensuring that we work together to develop a strong and capable health workforce for in the interest of our people, and ensuring that we are able to respond to old diseases like TB, but also to emerging infections like COVID. And stay well, keep safe, and I hope to hear from you through the different engagement platforms. Thank you.